Hello everyone, my name is Dr. Singh and today I'll be talking about a very important cardiac drug that is digoxin. So whenever you start reading this drug, there are a lot of cations which are involved in it, such as the sodium, potassium, calcium. There are a lot of pumps which are going on, such as the sodium potassium ATPase pump or the sodium calcium exchanger and the calcium channels, plus the sarcoplasmic reticulum itself, sarcoplasmic reticulum. So I'll be breaking down this image in my line diagram in two parts. So first, just talk about the sodium potassium ATPase pump. The whole purpose of this pump is to pump in potassium and pump out sodium. That's it. So as it pumps out sodium, there's a gradient which is maintained because the sodium in the myocyte or the cells become less. So to bring back the sodium and to neutralize this, it brings in sodium but exchanging calcium. And what this happens via this sodium calcium exchanger. So this part, the above pumps and everything is done now. Let's just come back to the sarcoplasmic reticulum. Sarcoplasmic reticulum is basically a storehouse of calcium. It also have two receptors which are attached to it. The one represented in the red is the ryanodine receptor, and the one in the blue is the SERCA. The functions of these two will be dealt in just a minute. Just told you there is one L-type calcium channel as well. In this image, it is represented here, the L-type calcium channel. Now, how it works is when an action potential is generated in the SA node or the AV node, it just get conducted via the myocyte or to the myocyte. It moves towards the T tubule and gets and attaches or activates the L-type calcium channels. And this L-type calcium channel releases calcium in the myocyte or the ventricular cells. Now, you'll think this calcium is enough to produce myocyte contraction, but the amount of calcium released from this L-type calcium channel is pretty low. It's not going to cause a myocyte contraction. So how it helps is, I hope you remember the sarcoplasmic reticulum I just talked about. Calcium, which is removed from this L-type calcium channel, activates this ryanodine receptor and says, hey, I need to produce some myocyte contraction. Give me some of the calcium which you have. The purpose of this ryanodine receptor is to release ampoules of calcium in the myocyte and thus causing myocyte or muscle contraction. Once the muscle contraction has been done, all the calcium with the sarcoplasmic reticulum released goes back in the sarcoplasmic reticulum via the blue receptor I talked about, SERCA. Done. But you'll think, what happened to this calcium which initiated this event? This calcium is moved out of the cell via this sodium calcium exchanger. So let's just recap this pumps again. The sodium potassium ATPase pump moves in potassium, moves out sodium, thus decreasing the sodium in the cell. To bring back sodium, I have to move out calcium. And which calcium is it? Now you know it. The calcium which was released from the L-type calcium channel. This is the same calcium which was initiated or was initiating the response of the ryanodine receptors to release lots of calcium. Now, if you have a basic understanding of all these receptors and all the anions which are going on here, it will be very easy for me to explain how digoxin works. Digoxin is basically a sodium potassium ATPase pump inhibitor. Now think about this for a moment. There is no net inflow of potassium, there is no net outflow of sodium. If there is no net outflow of sodium, do you think the sodium calcium exchanger will send more sodium in and move out more calcium in? No. So eventually, let's just focus on the sodium here first. As the sodium goes high, the sodium calcium exchanger also gets inhibited. All the calcium which is in the cell starts to rise. As there is more action potential produced, there is more calcium released from the L-type calcium channel, there's more calcium in the cell, and there is a stronger response to the ryanodine receptors to produce or to release more of calcium. So as more of calcium is there in the myocyte, there is better contractility. is increased muscle contraction. And you think all the muscles, all the calcium which is in the muscles can accumulate there. So there is more net inflow of the calcium by the circa in the sarcoplasmic reticulum. So with every beat, I have more calcium for contraction. Simple. So again, I'll be talking about this receptors again. I've talked about the sodium, I've talked about the calcium, basically, which is the main action of digoxin is to increase the calcium in the myocyte, thus increasing the myocyte contraction, better contractility. What happens with the potassium? Since there is no net inflow of potassium, their digoxin usually cause hyperkalemia. I hope it makes sense now. Now, just consider this as a myocyte and the green, it's representing the sodium potassium ATPase pump. If I give my patient digoxin, not all digoxin is acting on the sodium potential ATPase pump. You see down below, some of the pumps are blocked by potassium, thus not allowing digoxin to act on it. Therefore, producing or preventing my patients from getting cardiac side effects of digoxin. Imagine this, we give digoxin where? In patients who are having congestive cardiac failure. What else do we give to them? To deload, that is furosemide or Lasix or loop diuretics. And these guys causes hypokalemia. Now, if a patient is having hypokalemia, the digoxin which I give to my patient will have amples of receptors or ample of pumps to act, thus increasing the chances, or will, if the patient is having hypokalemia, the patient will have digoxin toxicity, the digoxin related cardiac side effects. This is one cation which I really want you to remember, calcium, potassium. So hyperkalemia is a side effect of digoxin. Hypokalemia increases digoxin toxicity. And what happens if the patient is having hypercalcemia? Remember, the sole purpose of digoxin was to increase intracellular calcium. The patient is already having hypercalcemia. The patient will have increased cardiac side effects of digoxin. And you know what goes side by side with calcium is magnesium. So hypomagnesemia will also have similar effects. So basically remember the three electrolytes, potassium, calcium, and magnesium whenever your patient is on digoxin. Key points, I'll just sum it up. What are the mechanism of actions we read about? First is the sodium potassium ATPase inhibitor, that is to increase the contractility of the heart. It has one more mechanism of action, that is it stimulates the vagus nerve, thus it acts on the AV node, decreases the conduction and decreases the heart rate. Find out where is it used. The patient is having arrhythmias, the patient is in AF, this type of drugs can be given. Uses heart failure, increases the contractility, arrhythmia such as AF. This is the slide, this is the go-to slide. If you understood nothing from the lecture, this slide you should remember. First is the mechanism of action you should remember, and the second slide is this, should be on your tips. So hyperkalemia, it's a side effect, but I shouldn't say hyperkalemia, I should say normokalemia should decreases the sensitivity for digoxin and prevents the cardiac side effects of digoxin. Hypokalemia, it increases the sensitivity for digoxin and can lead to digoxin toxicity. Hyperkalemia also leads to arrhythmias, and hypomagnesemia is increased chances of digoxin related side effects to heart. What are the side effects I'm talking about? Basically arrhythmias, the most common being the ventricular bigeminy, ventricular tachycardia. The one I have marked with the arrow is the most unique type of arrhythmia which occurs with digoxin, that is the atrial tachycardia plus an AV block. Where else do you see? It's the most unique type of arrhythmia you see. There's a block as well as there is a tachycardia. So super. Rest could be nausea, vomiting, yellow vision, and hyperkalemia, as I already explained. There are some contraindications where you don't want the drug to act, such as the WPW syndrome. Think about it for a moment. Your patient is having a extra pathway for conduction, also known as bundle of Kent. Now you block the AV node, all the conductions from the atria will move down through the bundle of Kent and can produce ventricular tachycardia, and these could be fatal as well. Second, as the drug is excreted out through kidneys, I don't want to give this drug to renal failure patients. The patient is already having AV blocks. I don't want to potentiate the block. Simple. Patient is having hypokalemia. I already explained how it increases the cardiac toxicity. Pregnancy and known allergy to drug. These are certain contraindications for the drug. So we are at the end of the topic. I hope you like the lecture. If you like, do subscribe and like the video, and thank you and stay safe.